Dr. Rabinowitz is the principal investigator for the Northeast Telehealth Resource Center and was elected to ATA's College of Fellows in 2016. So welcome, Terry, and it's all yours now.
Thanks, Anita. Thanks, everybody, for inviting me to be here today. I don't know if I probably won't be able to hear other people, but if there are questions during the presentation, I'm comfortable being interrupted. So if someone's chatting, or Anita, are you watching or keeping track of that? Okay, great. So I'll get started then. I wanted to say thanks to Reed Plimpton and the entire Netric team. Mike Rickey is probably not on this call, but he is the past medical director of telemedicine, is the guy who got me started in telemedicine. I want to thank all my telehealth resource colleagues throughout the country. I want to give a shout out to all those willing to give telemental health a try. And most important, I want to thank all patients and their families who place their trust in us. Thank you all. Here's my ultra brief bio sketch pertinent to today. I was born in the Bronx. I got my bachelor's degree at Herbert Lehman College, right in the City University. I lived at home during college. I went up to SUNY at Stony Brook for my dental degree. That was a little bit of a pathway change. I got my MS degree from the University of Iowa in children's dentistry. Then I got smart and I went back to school and got my MD at Case Western Reserve, and then did psychiatry training at McLean Hospital and Mass General. And I moved to the University of Vermont from Boston with my wife in 1996. And most important there is I never thought about telemental health at that time. And here's my real bio sketch. I'm a son, a brother, a husband, a DOD, that's a dad of dogs. I'm a fly fisher. I started roasting coffee during the pandemic to stop from going insane, and I'm loving that. And I love world music, especially bossa nova. Here's my intro to telemedicine. I came here in 1996 to be the medical director of the Psychiatry Consultation Service. And we consult to every medical and surgical service in the hospital. And this kept me very, very busy. For those of you who don't know what consultation liaison psychiatry is, it's basically psychiatric care for people with comorbid medical or surgical conditions. So this kept me very busy. I hadn't done any telemedicine, wasn't especially interested in doing it, knew a little teeny bit about it, but a colleague, that's Mike Rickey, reached out and asked me to become interested in developing a telepsychiatry consultation program. He told me there are lots of underserved people in our region, and also in an adjacent region, that is upstate New York. Lots of underserved people who weren't getting timely and appropriate mental health services, and that telemedicine might be a way to address the problem. So I said, okay. And however, there's some barriers to receiving mental health care. And these were some of the barriers we had to consider. Rurality, severity of mental illness. That is, people in very rural areas clearly don't get the same types, frequency, and quality of mental health care that those in more urban areas are likely to receive. Those with chronic mental illness are significantly underserved. The types of mental illness may also put people at a disadvantage with respect to getting appropriate services. So if you're hallucinating, if you have delusions, if you have a personality disorder, many people will shun you and not be willing to provide the care for you. They cherry pick, as it were. There's racial disparities, ethnicity disparities, and certainly people with different sexual orientations. Many of the LGBTQ community are significantly underserved. Also, if you're earning less money, you have less ability to get the care you need because you may not have the ability to pay for the right insurance or the right provider. And those with lower educational levels are also at a disadvantage. Well, first question, or one of the first questions, was who needs help? There are many different populations lacking adequate mental health services, both in Vermont and rural areas of New York State. There are small communities that can't financially support a psychiatrist. There are underserved and vulnerable populations, including prisoners, those with serious mental illnesses, veterans, homebound persons, and then there's older adults and those in nursing homes who are also very vulnerable and significantly underserved. To start things off, I had to make site visits and do some paperwork. And I chose nursing home as my venue for care delivery because nursing home residents are really significantly underserved, and because I like that population. And I also think we're all going to be old someday. It's nice to, maybe do something that will actually make a difference, and maybe
Just unmuted. This is on.
So we have enough like with shrimp feeders who can make those.
I'm sorry, there's some talking
Okay.
in the background.
And, got enough.
So I made some site visits. When assessing the location, it's important to know what the room is like. That is, where is it located? How are the lighting and acoustics? And how close or far is that room from key personnel? This is especially important in a nursing home where I rely on key personnel to help with patient placement, making sure the patients are safe, sometimes repeating something that they don't hear clearly from me, placing in front of them the various things that I might need to do a mental status exam, such as a piece of paper, so that they can write their name or a sentence. And the lighting and acoustics are essential because many of the patients I see, but many of the patients that any of us are likely to see, will have vision or hearing problems. Also want to make sure that we know who's available for an emergency and how quickly can emergency resources or services be summoned. And so I always have a backup. I always know the cell phone number of someone who's available, or of the nursing home and the administrative staff, so that if there's a major problem, I can call for help. I do that as well with my non-nursing home patients. So what have I learned from almost 2 decades of telemental health encounters? This is over 500 encounters for more than 300 patients, numerous family meetings, many challenging patients, as well as some challenging colleagues. I learned that P4 is essential: proper pre-planning and practice. Make sure you have real technical experts at the provider and the patient sites. Don't count on yourself to troubleshoot and solve all problems. I think as physicians, and perhaps others I'm speaking to here, we like to think of ourselves as being all powerful, all knowledgeable. At least I like to think of myself that way from time to time, till my wife tells me otherwise. But you can't troubleshoot everything. I don't have technical expertise in all these areas, and so there are real experts who are available to help. Build redundancy into the system. That is, if you have a dropped call, make sure you've got a cell phone or a landline to pick up and call for help. Even continue your consultation using some other methodology. What's the safety plan that you have in place? Make sure you do have one. What do you do if someone says, I'm actively suicidal? You may be hundreds of miles away from that person. What can you do to keep them safe locally? It's very important to consider these issues. And practice. practice, and practice. Make sure you do several telemedicine test runs to identify potential problems with the service. That is, how was the connection? Did you have drop packets or calls? And how did it work for you? That is, you as the provider. Did you feel comfortable? Did you have good telepresence? It's a wonderful word that I think really is one of the top 10 words you should keep in your telemedicine glossary. That is, how did you come across to the person on the other end? Because if you came across naturally, it's likely that they felt more relaxed and more comfortable with what you were doing. And so it's likely that they were more accepting of the care delivery, of the service, of the difference between this modality and the in-person condition. Likewise, how did it work for the distance side? Did they tell you you had good telepresence? Now they're going to say, hey, you had good telepresence, but they are going to say, hey, you seem pretty natural. You made good connection with the patient. You didn't seem like you were 200 miles away, and you didn't fidget a lot, and you didn't apologize for the lack of clarity in your call, or when there was a breakdown, you just rolled with the punches. All of that is part of telepresence. Did those at the distance site identify any problems? Because it may look fine from where you're sitting, like it looks fine from where I'm sitting right now, but you may be seeing me looking distorted or breaking up or whatever. So we want to know what both sites were like. And I think most important there is take all the comments seriously and act on them. And don't think of them as any personal affronts. View it as an opportunity to make your service better. There's other variables to consider. Video etiquette might be a good term for that. Where is the camera placed? Who is it facing? Who is it not facing? What room are you in? Is there extraneous noise? If you're working from home, can someone hear your spouse or partner preparing dinner? Or is there a dog that keeps coming in and bugging you? Or are there sounds outside of your office that are distracting? What's the microphone or sound quality like? What's the picture quality like? Are there verification protocols that you can use to make sure that people are who they are, that you can access various parts of the electronic medical record, et cetera, with ease? Keep in mind that your speech and sometimes your picture don't transmit in real time. There may be a half a second delay, but that may be enough so that if you don't pause between sentences or pause after you ask your patient a question, he or she may not be able to answer you, or you may talk over them. And it's just nice to mute yourself when you're typing if you can. And it sounds that way because, if you're typing on the keypad and that keypad is right next to the microphone, it may be very loud and distracting to your patient. Lighting is important. Before I went live today, I checked with Anita to make sure that she could see and hear me okay. I wore a shirt that doesn't have too bold of a pattern. I gave you a nice background. That actually is my backyard in the fall. I could have picked some spacey background that Zoom gives me, or you could have just seen my bookcase, but I thought this one would work. Again, I checked to make sure that that background was okay before I went live. Do you have someone available to help? And how can you reach them? And if you are able to have a wired connection, an Ethernet connection, that will likely work better and faster for you than a Wi-Fi. And most important here, the point I want to make, and one that doesn't work for me yet, is do you have electronic health record integration with the distant site? I do not. And that is a major loss for me. I'm dependent on the nurses during my telemedicine consultation to read me laboratory values for the patients I'm seeing, to read me old medical records. We're working towards getting integrated, but it hasn't happened yet. So I want to tell you about what we learned and we published about some telemedicine work that we did. And I'm telling you this for a couple of reasons. One is it's fun to brag. So I'm not being modest about that. It was work that we did. I did with a large group of folks and collaborators, and we were happy to get this published. But I also tell you it more as a colleague, and that is to say, this research cost us nothing to do. We were able to get all the information from our database that was already established because it included billing information, site information, etc. That's just kept as a normal part of our general care provision. Title of the paper is Benefits of a Telepsychiatry Consultation Service for Rural Nursing Home Residents. Here's what we learned. The characteristics of 106 different nursing home residents for 278 encounters. The average age was about 77.5 years, and about 2/3 were female, which is typical for a nursing home or nursing homes. Depression, dementia, and delirium each comprised about 21% of the diagnoses that we made. Adjustment disorders were present in about 12.5%, and behavioral disturbances were present in about 17%, and these were exacerbated by vision and hearing problems. And I emphasize that to you because this doesn't only apply to nursing homes. One of the things we learned early on was that a lot of patients came to their visits without their glasses or missing one or both hearing aids. And those hearing aids and glasses were not easily found. Some of them had been broken or completely lost and never found, and patients were not able to get a new hearing aid or new set of hearing aids because they'd used up their monetary allotment for the year or lifetime or what have you. And what we found that worked really nice was just get a cheap pair of amplified headphones that could connect to the telemedicine apparatus at the distant site, and we put them on our patients. And wouldn't you know that their mini mental state score went up often by several points because they could actually hear again. And that led us to recommend that that individual patient's hearing be reevaluated, or that wax be removed from their ears, or that their hearing aids be cleaned, or that the batteries be replaced in their hearing aids. Very simple interventions, nothing to do with telemental health directly, but made a big difference in that patient's quality of life and their overall function. The results that we got were really interesting and important. I've circled what's important here, but I want to go over some of the other items just quickly so that you get an idea about what we estimated. We estimated that the travel time that would have been spent by a provider to get to nursing homes would have been a total of 35.1 days. That is travel, not an 8-hour day, but a 24-hour day. So hundreds of hours would have been spent making the trip to see these patients. The distance that would have been traveled was 43,000 miles. That's a lot of travel. Fuel costs, $3,500, $4,000. Range of personnel costs, that is, to have someone bring a nursing home resident to see me requires that at least 2 people be in attendance, one to drive the van and one to be in direct face-to-face contact with that resident. If I were to travel to see that patient, my round trip would be pretty extensive. And so I would have to spend hours and charge for those hours. And we estimated that the charges might be as high for these 278 encounters as more than $250,000. When we subtracted the costs for telepsychiatry, we came out with a potential savings as high as $232,000 plus. That's a lot of money for just a small number of encounters, relatively speaking, 278 encounters. So we were able to show this just by making these estimations, and we sent it off to the Journal of Telemedicine and e-care, and it was accepted for publication. Turned out to be one of the first papers of its kind. That is, when this was published in 2010, nobody else had published on doing telepsychiatry for nursing home residents. I don't think anybody had published about doing telemedicine for any nursing home residents at the time. And this is one of the first papers to just simply do a cost and time estimate that was pretty accurately done, and so was felt worthy of publication. I got more telemedicine education than just that. Back then, the equipment was bigger. It was larger, it had a heavier, it was taller, it was more cumbersome. It was more expensive. It was in the thousands of dollars. It was less reliable. We expected to have 1 to 3 drop calls or suboptimal packets for every 10 calls or so. That's a picture of one of the apparatuses I used. It originally sold for $6,000. Now you can find it on the internet for $895. The reason I tell you that is that you shouldn't buy it because it's not supported or hardly supported, and it'll drive you crazy. But that's what it cost back in the day to get started in telemedicine. Now, I can get about the same quality image and better reliability with, for example, a Logitech webcam or its equivalent, and that's what one looks like. And that's what I use in my office for my telemedicine encounters. It's just a little ball on a stalk, and you can see that little remote control. I can pan, tilt, and zoom that camera. I also have remote control capability at the distance site using the same camera. It's really cool. And it costs $300 list, but you can probably get it for less. Image quality is superb. That's me in the day. And you can tell that's me in the day because I have hair. But just to show you, it was kind of cumbersome. And sitting on top of that TV screen, sorry it was cropped out in the original photo, but you can see just the hint of that Polycom equipment. And that was taken in the mid-2000s. I think it's now available online. Someone told me it got published recently as a picture of what people are doing now in telemedicine. But that's back in the day. I don't have a picture of me now because we're not allowed to take any more photos of us doing telemedicine. Here's another then for you. There were many more technophobes back then. That is, people who were less willing to try the modality. They had less or no confidence in it that it would work. And now there's many more telemedicine adopters. It's likely due to multiple factors. It's way cheaper. It's easier to access, and it's supported by hard data. There's many more published studies documenting improved outcomes. It's usable for many diagnostic categories, and there's patient and provider satisfaction, all that have been well documented. And of course, I know I'm speaking to the choir a little bit today, but as of late, you know that you can do a telemedicine visit just with a simple mobile phone, and the quality will be reasonable. It may not be ideal, and you may not want to read a pathology slide like that, but it certainly works for a lot of telemental health applications. I say that because everyone's connected. I don't mean everyone because, there's rural places in Vermont where people don't have cell phones. There's rural places in a lot of other areas where there are not great accesses yet, but hopefully. And I made up a term, herd non-immunity. That is, by using this more often and people seeing it used, others around the users are likely to adopt it themselves. So herd non-immunity, you heard it first here. The more users you have in a community, the more likely you are to get more users. Back then, there was less or no institutional support. Administrators want to know, will it work? What will it cost? Who will pay for it? Who will compete with us? What about liability? How safe is it? What about the service? What do we have to sign on to? There was less or no insurance support because the insurers felt or said it wasn't as good as face-to-face. And licensure, malpractice insurance, and credentialing hassles were big impediments to its use. Now, institutions are happier with it. Go figure. It likely does save time and money, and patients are happier and are seen more quickly. Insurers sometimes still squawk, but many states have mandated coverage and parity for telemedicine services, likening them to inpatient services and requiring that they be paid at the same or similar rates. It's also much easier to get insurance, get credentialed, and to get licensed to provide this care in state or out of state. That doesn't mean it's automatic, so a caveat to you folks, if you haven't already started doing this, is to make sure that you have the appropriate coverage, make sure that you have the appropriate institutional support, make sure that you have the appropriate licensure wherever you're going to be practicing. The new now. It's all being run by this little bugger. That's artist's rendition of COVID-19. Here's what's happening. Here's what I've observed with COVID-19 and telemedicine. There are challenges. This virus caught us by surprise. Many individuals and institutions were not ready to get up to speed with respect to telemedicine. There was an exponential spread of the virus from city to state to country to the world. Social distancing is essential. That's had a significant negative impact on many patients and providers. I take care of many of them who are suffering because of the lack of interpersonal contact. I have to take care of colleagues who are struggling with this social distancing. It sucks. Some are having exacerbations of pre-existing conditions, and some are developing additional new conditions because of this. We have to mask, gown, and glove, and wash, and wash. And I say, this costs time, and time, and produces hassles, and hassles. But it's also given us opportunities. Many experienced telemedicine providers, researchers, administrators, including all the TRCs, jumped right in. We help new users to get started and existing programs to grow and adapt to this new pandemic. Department chairs, hospital administrators, professional societies added their support to this endeavor. States, insurers, CMS, and others lifted restrictions on who could provide telemedicine, where they could be provided, and what technology could be used. That made a big difference. For example, some providers in Vermont can consult to New York patients without having a New York State license. That was not the case before the pandemic struck. Medicare requirements were significantly relaxed, and so they have been willing to cover a wider array of services. They've been willing to cover patients receiving care in metropolitan statistical areas, which they didn't previously cover. So that's made a big difference as well. And telephone has been approved for some consultations where it has not been allowed previously. More insurers are covering services, and they're putting up fewer barriers as well. So everybody, in my opinion, has come together on this in a very surprising and gratifying way. It's been very nice to see everybody jumping in and really trying to help each other. What about this? 1 out of 1 psychiatrist's observations and predicted fallout. That's me. We've made lemonade from lemons. There's more telemedicine patients and providers now in every field, not just telemental health. We're showing that it works, it's cost effective, it's easy, it's well accepted, and it's convenient. That's because more people are using it now. We're having to use it. I have dozens of colleagues who have started telemedicine for the first time since the pandemic hit. And you can't or shouldn't go back. That toothpaste is out of the tube now. We're going to have more regular and permanent users. We're going to have more regular and permanent telemedicine providers because it works. And it's incredibly convenient. Imagine if we didn't have this, what might be happening. Many of us, many of our colleagues would be out of jobs completely right now because they could not be able, or might not be able to go into work because of social distancing, but they're able to still work now from home or from their home office because of telemedicine. And I think it's a great complement to in-person care, a super complement. So I think it's really headed in the right direction. Here's a fun fact I just learned in the past few weeks. More patients are keeping their appointments via telemedicine. That's something I learned from a colleague who is chair of psychiatry in Texas, and he got his whole department to convert to telemedicine early in the pandemic. And those patients are showing up at higher rates than they did previously. Many fewer. Can you have many fewer? Yeah, fewer no-shows. Here's what I've learned, part 2. If you act like telemedicine works, it's going to work. If you apologize or criticize or in some other way suggest that telemedicine is inferior, you're guaranteeing that your patients and your colleagues will see it as inferior. Make sure you acknowledge and appreciate the hard work done by all of your colleagues to optimize the telemedicine encounter. You know, some of the members of the Northeast Telehealth Resource Center may be on this call. I love my colleagues in this TRC. They are awesome. They're so responsive. They're so knowledgeable. They're so hardworking. This is the same for all the TRCs, our hosting TRC. Thank you to all of you. But also want to remember, to make sure you all remember, there's lots of people working behind the scenes. There's technical staff, there's social workers, there's nurses, there's family members who are saying, we really appreciate this. We really appreciate that you're doing this. But they're also putting their faith in us and saying, we'll give this a try. Yeah, you're not going to touch our loved one today. You're not going to examine them face to face or in person, but we'll give this a try. Really acknowledge their commitment to making this work. Make sure you're accessible, and you know how to do that. I give my patients my cell number. They haven't abused it. I give my colleagues my cell number. They haven't abused it. I want people to be able to reach me if they need me. And if I'm doing telemedicine and something breaks down, they can call me quickly on my cell phone. And I tell them that, if you lose contact, just call this number. Learn to roll with the punches. Telemedicine isn't perfect, but neither is face-to-face. Sometimes there's going to be a drop call. Sometimes it's going to be poor image or sound quality. Sometimes it's going to be frustrating because someone at the distant side can't find the information immediately. Sometimes a patient's not going to get it, and they're not going to recognize that you're doing a telemedicine consultation. That happens to me with some of my patients with dementia. Roll with the punches. Learn to chill. You'll get it. It'll work. Just let it happen. Let it evolve. And also keep in mind, the telemedicine technology is really off the charts now. It's so speeded up now. So there's going to be bigger and better things for us, and smaller and better things too, because telemedicine is becoming more compact. The most important thing I've learned is look at the camera. That's my friend and one of the icons in telemedicine, Elizabeth Krupinski, who shared this slide with me. I think it's a great slide because we often forget to just pay attention to that little dot in the upper part of our screen. We keep trying to make face contact with our patients this way, but we should be looking up at that camera. You will have a better telepresence that way, and I think you'll be happier in the long run. I thank you very much for your attention and for the invitation to speak today. There's my contact information. There's Netrix contact info, and there's the little code that you can click on to join our newsletter. And now we're open for questions. So thanks so much.
You're welcome to use the chat function if you wish, or you can unmute yourselves and ask questions of Dr. Terry directly.
And how will I know when a question's coming in?
If the chat function, I can read to you.
Okay, that'll be great. Let's do that.
Okay.
Hi, this is Rocky, and I'm wondering if I'm coming through nice and clear.
Beautiful.
Wonderful. If that changes, let me know, because I'm wasn't able to get my computer on quickly enough, so I'm doing this on my cell phone.
I'll only tell you I can't hear you if it's a hard question.
Perfect. First of all, just thank you so much for an exceptional presentation. I just am so grateful that you're sharing your experiences.
Oh, thank you.
And I'd really love to hear more about, I am an audiologist, so I'm familiar with the hearing implications of what you were talking about, but I'm not very familiar with the ways that visual impairment can impact telehealth. So I'd love for you to talk more about visual impairment, and maybe in general, any of the things that you found that make it harder for patients to access telehealth, and which of those are things you're able to overcome, and which are problems that have meant the patient can't benefit from telehealth.
That's a great question, Rocky. Thank you. So we found that the visual problems had a significant impact on patients' ability to work with us, because they had a little trouble seeing the screen or seeing the image on the screen. And oftentimes those images are smaller than life size. And so that was a major problem for them too. the most common eye problem or vision problem in elders is macular degeneration. And so that's generally a progressive problem that makes central vision more difficult. And some patients really had difficulty seeing me. Unfortunately, there were not a lot of fixes for that. And so we had to deal with the vision problems in the best way we could, but oftentimes not very effectively. And we would just have to acknowledge that they couldn't see us very well. And we were hoping that they could still avail themselves of the consultation. The hearing problems, as I outlined earlier in the talk, were much more easily resolved. Not in everyone, but in many of those patients, just by simply using these amplified headphones. What I didn't mention is you haven't seen anything cuter than a 93-year-old elder wearing a pair of headphones. They look like little old DJs. And I don't say that in any way disrespectfully. They were really sweet, and they could sometimes see their own pictures, and they thought they looked pretty cool as well. Rocky, was there another part? I think you wanted to know some of the other problems we encountered. Is that correct?
Yeah, just if there were any people that you had hoped would be able to benefit from the service who really just weren't able to connect or weren't able to overcome sensory barriers.
Mm-hmm. The sensory barriers, as I said, there were some people. We had a couple of patients who were blind, but who could hear me okay, and so that wasn't a problem. There were some people who were deaf, who actually really couldn't benefit from speaking with me, but with the help of people at the other side, that is the nurses and the social workers, I was able to carry on a pretty decent examination and communicate with them pretty well. So that wasn't a major problem. You'd actually bring up an important point. We were amazingly surprised that virtually everybody understood what I was doing. And in our paper, we even quoted a couple of patients, both of whom had dementia, not severe dementia, but mild to moderate cognitive impairment dementia, one said, "It's pretty cool, doc." And another one said, "It saves you a trip." So they actually understood what we were doing. So another reason that works is because many elders are more familiar with the telemedicine approach than we give them credit. Because a lot of them stay in contact with their grandchildren when they head south for the winter. And they do that by Skype or Zoom or FaceTime or something. And so they become pretty good at it. You know, you take a grandma away from her grandchildren, she'll learn, nuclear physics in order to be able to see them. So I was really surprised and happy about that. Does that help, Rocky?
That's wonderful. Yeah, it's and if nobody else is asking questions, I'll also follow up to say, how many people? Two more questions. What proportion of people do you think had macular degeneration or blindness that impacted their interaction? And then I forgot the other question because I was trying to phrase that one nicely.
Oh, that's okay. I don't have exact numbers, but I'm going to estimate that probably 15 to 20% of them had some kind of visual impairment.
Great. And I missed the very, very beginning of your talk. Are you still delivering these services? Like, this is still your professional work now?
I am indeed. I did my last consultation, telepsychiatry consultations on Wednesday. I do them every other Wednesday morning. I consult to Alice Hyde, or now it's called Alice Center. It's part of Alice Hyde Medical Center, a nursing home with 175 beds in Malone, New York, a tiny little town. And my other consultations were done to a small nursing home in Middlebury, Vermont, but those stopped several years ago because they were able to find a local psychiatrist who would stop by. So yes, still ongoing, still loving it.
Fantastic. Thank you so much.
You're welcome. Are there other questions? Well, I got away easy today. Let me forward a slide. Here is our request. Let us know what you thought of this session. Of course, only 5 stars will be accepted. So, but do let us know, please. And I want to say thank you to the Mid-Atlantic Telehealth Resource Center for hosting this conference and hosting me today. And special shout out to all of you folks. Thanks a lot.
Thank you very much.
I don't know what to do now. Do I just sign off, say goodbye, or wait if there's any other?
If no
final
one
words?
has any additional questions, that you can sign off. That would be fine. If anyone does have questions that think of after the fact, they can probably connect with you via the agenda. You have your email on there. So
Okay, sure.
that's a continuing resource.
Sure.
Thank you again.
Shall I give them my cell phone number again? It's up there.
That's up to you.
Yeah, let me go back to, do they have copies of the slides?
Yes, they
Oh,
can.
okay. You have copies. So there's my cell number. Call me if you want to talk.
All right. Thank you very much.
Stay safe, everyone. Have a good weekend.
Bye.
Bye now.